I will introduce our guest today and we will get started. So first of all, Matt, big thank you, mahalo for joining us today and
Thanks.
for attending, for sharing at this meeting. Hope and I heard Matt speak at a conference in California, and we were both like, wow, let's have him talk to our folks in Hawaii to see what they think about how they've been moving forward. And because of Ira Byock's longstanding connections with Hawaii, Providence is a group we know. So thank you very much. So I have a short introduction and then we'll get into it. So Dr. Gonzales is Associate Vice President and Chief Medical and Operations Officer at Providence Institute for Human Caring. So if folks haven't looked up the Institute for Human Caring, and after today, I think you'll be interested in that. Matthew is a fellowship trained board certified palliative medicine physician, a 2017 Cambia Health Foundation Sojourns Scholar Leadership Program awardee, and a Catholic Health Association Tomorrow's Leaders recipient. He completed his undergraduate degree in human biology at Stanford, my hometown, and as a software engineer, helped develop a public database that allows clinicians to tailor treatment for those with HIV. Dr. Gonzales attended the Keck USC School of Medicine and completed his internal medicine and palliative medicine training at UCSF. So thank you again, Matt, Dr.
Matt's
Gonzales.
great.
What do we
Yeah,
want? Okay,
that's
Matt,
great.
then take it away. Thank you so much
Thanks, Jeanette.
for being here.
Thank you. Thanks for having me. I feel really humbled to be here today. As I said to Jeanette when she came up to me after the talk that I gave, I was like, "You write the newsletter?" Like I felt like I had met a celebrity, and considering I live in Southern California, that's like not uncommon. But I will just say that like meeting you and Hope was just very exciting because I had subscribed to that newsletter in 2013 and look forward to reading it every time that it comes out. And I have just been, as I said on the pre-call, I feel like really inspired when I get your newsletter and see all of the amazing work that is happening in your state. It's just breathtaking and it's inspiring. And the new benefit that you were all just talking about, like it feels like such a model for the rest of the country. So bravo to all of you. Thanks for having me. I'm going to spend probably like 40-ish minutes sharing a little bit about the work that we've been doing over the last almost 10 years here at Providence. This talk was originally designed for me to give with a social worker, Suzanne Engelder, who's on our team. She actually got sick for the coalition and she can't be here tonight because of some other family stuff, but I wanted to just share a little bit of her perspective, and mostly because you're going to see a photo of her. This is a photo of her, Suzanne, and her two young kids in June of 1990. That is her littlest daughter in her hands, and her husband, Tom. At the time when this photo was taken in June 1990, her second daughter had just been born. And at the same time, the Patient Self-Determination Act of 1990 had been signed. And she was a social worker in oncology at the time. And she thought to herself, like, the world is about to change. Like, although she talks and tells this story about like her tiredness, she also shares this sense of recognizing and looking towards the future and feeling hopeful for the future because she witnessed the sense of having people die badly in oncology care and wanting to be able to look forward towards a future where people just showed up with advanced directives and people understood and talked about these things before we saw them in a crisis moment, where we had a sense of who people's people were, like who they loved, who loved them, everything written down in a beautiful document that we could all easily find and retrieve and be able to look and to be able to have what we all want still, which is goal-aligned care and shared decision-making. And I'm saying this now, and I think most of you on the call that I'm seeing nodding, recognizing that we're not there yet. And that actually, like in the time since, and it's hard to believe that was 34 years ago, but true, right? that we've made some progress, but maybe not as much as we would want, right? Here's one study that we showed, you all have seen this, right? And I think this is based on California, but I don't think it's unique to California, that most people say in general, when you ask them, about 80% or so, like, do you want to talk about this? Do you want to have a conversation around what it looks like if you get ill in the future? Or now, if you are ill, and yet at the same time, we're seeing that depending on the study, 7, 10, 15, 13, maybe 20% in some higher studies suggests that we're having those conversations. And the reality is, like, that's a huge gap in healthcare, right? Like, and that's where I think that our group in particular has tried to focus in terms of these gaps in healthcare, particularly around the idea of whole person care. The gap being, right, that patients and families, people, all of us are saying it's important to talk about this, and at the same time, we're not delivering on that. So the Institute for Human Caring was founded 10 years ago as a step of Providence in terms of trying to be able to address this. It was founded by a dear boss at first, and then colleague, mentor, friend, Ira Byock, who I worked with very closely day in and day out for the 8 years that he ran the Institute. And then about 2.5 years ago, I stepped into his role, and Ira retired. He's actually in Copenhagen right now for 2 weeks, and loving and enjoying life. But we were founded really, this is a long description, as an interdisciplinary team of a different kind. We're clinicians, educators, IT specialists, systems change experts that really believe that every person at any age or stage of life deserves the best care possible for their physical health, including emotional, spiritual, interpersonal, and social well-being. I'm not going to go through all of the individual pieces of this definition, but what I want you to take away is that we want to really transform healthcare. And our goal is to transform healthcare, not only within Providence, but beyond. And what we really mean by that is we envision a world where we can go from volume to value, from fee for service to financial risk bearing, from a transactional world where you're reaching out to your healthcare system when you need it, to a relational world, from a problem-based intervention to something that's experienced, to a world where more interventions means more money for healthcare systems, to a world in which better care means more dollars for care centers, to being reactive, from being reactive to proactive, and really ultimately trying to achieve this goal where health without problems is enough, but well-being is important. So it's possible to be able to recognize and do this even when you're sick. We believe really at a core level that means that we try not to use the word patient very often, but we call people, our patients, as whole people. Been trying to incline us away from the words of individuals to persons within families and homes and communities, from problems to health and well-being, and treatments really to human caring. And those are, if you know Ira, you know these are big ideas. And our group, really a team of somewhere between 15 to 30 of us, depending on how you count, has really operationalized and tried to think about how we can take these ideas and operationalize them, to routinize them, to make more routine this idea of highly personalized care. Now, we are certainly not there yet, as you'll see, but we have been imagining this future for the last 10 years. And I think we have some successes, and we've had some places where we've had some missteps. And I think the story that you'll hear today about our advanced care planning journey has been a bit about both of those. As many centers have done, we've tried to really discretize things, to be able to make it a little bit easier for folks who are not specialists to think about the ways in which we talk about having these conversations over the course of a lifetime. And that's where we've really spent a lot of time and effort over the last 10 years, is trying to identify these crucial conversations that need to happen over the course of someone's life. The early advanced care planning conversation, right, around all adults 18 and up should have some sort of conversation around at least who speaks for them if they get in a car accident. The later goals of care conversation at the diagnosis of a serious illness that really is talking about what the meaningfulness of life is in the context of that serious illness, what someone's hopes, dreams, worries are in the context of that, and then sort of operationalizing that later with the worsening of illness with a pulsed form. more recently, we've actually been expanding this definition as we're working within the age-friendly health system framework of what does healthy and connected aging look like. But I would suggest that we've had some successes. So for instance, we've spent a lot of work on goals of care, in particular in our acute care settings. I'm really pleased and happy to say that we've had a ton of success. So last year in our ICUs, across all 52 of our hospitals, 73% of our patients with a 5-day length of stay or more in the ICU had a goals of care conversation. And that's like remarkable across a large health system. What that looks like for us is last year alone, we had 77,000 goals of care conversations that met some baseline minimum criteria in our electronic health record, which like this is like what gets me up in the day and morning, right? To be able to like think about this, to first of all be able to like measure it, display it, and be able to measure some sense of quality has been just a true privilege to be able to move forward. This most recent year, year to date, our stats continue to improve. We're at 84% of all patients with an ICU length of stay of 5 days or more. And we've done a lot of work around this. We've done Epic templates. Most recently, we've actually embedded GPT into Epic to automatically detect these conversations so that we don't have to do anything different. We've built out an AI conversation simulator so that people can practice these conversations safely without needing to hire an actor, without needing to put a lot of infrastructure around all of the training. And we've done a lot of it. We've trained 5,000 people. But we still think that there's more room to grow within this. And I'm going to leave goals of care because, but I had to give a nod to it because I think you'll see that like, while the goals of care stuff has been easy for us, if I really focus in on advanced care planning, that's been a harder story for us. We have tried and tried and tried. In fact, I think Suzanne says it best is like, we have really tried everything, every trick in the book, trying to eke out, figuring out how we increase the advanced care planning rates across our health system. And when I say everything, I'm sure there are other ideas out there, but like we have hosted large scale events, right? This is an 800-person auditorium pre-COVID, obviously, where Ira gives like a very inspiring talk. We have hosted National Healthcare Decisions Days in various parts of our hospitals. We actually built, Suzanne, who co-gives this talk with me, her husband helped build us a Before I Die wall. This was at UCLA a number of years ago, where we tried to engage healthy college kids walking through a college campus around like, before I die, I want to. We have screened the Being Mortal film around Atul Gawande's book, which if you haven't seen is really worth a listen or watch. We incentivized our own caregivers. We all get these like health incentive dollars to be able to do something. And usually it's like around, I don't know, checking in with your doctor or going for a walk or whatever. In 2016, we incentivized completing advanced directives for our own caregivers because we thought it would make it really easy to say, well, I know this is a hard conversation, but I have an advanced directive, and so does every other staff member in this clinic, because that's just a normal routine part of being an adult, and it's hard to talk about. And sometimes healthcare maintenance is not all that easy, like a colonoscopy. And sometimes this is in that vein of like having a difficult conversation, but certainly important. We have even resorted at one point in time to having a wheel where we were giving away like Apple products to try to incentivize like people doing this. And it kind of all worked. I mean, these are like the photos that I could show, right? Like we even hosted a class at one of our hospitals every week for a year. And at most, we ever had 2 people enroll. We even tried, and this was the most creative idea that I think we came up with. Because we recognized notarization was a challenge, we trained and paid for all of our security guards to become notaries in all of our clinics. because we thought, well, wouldn't that be wonderful? You have the conversation, right? Like the challenge is the notary and getting it back. So we'll train the security guard, who, yes, is there for very important reasons, but most of the time they have a few minutes in their day to be able to notarize a document. And it kind of worked, but we also took a lot of inspiration from other things, right? So not only our own ideas, but also your state, others around this work around advanced care planning. I think this was a fabulous study that was done years ago in Hilo around the use of the advanced care planning, the ACP decisions videos, which cover really challenging topics, right, in multiple different languages. We did a trial of that too, and it felt like there was potential there. It felt like there was something, there was a there, as we say, in terms of showing these videos and breaking these concepts down into patient-friendly communication tools and to being able to advance the conversation. We actually tried these in our favorite clinics to try everything out in, and in the first week, they showed 36 of those videos, which I thought wasn't bad for two primary care docs to be able to show like 2 videos over the course of, or to have these 36 videos shown. And then weekly viewings. This is what happens. Those of you that have done a pilot know this is what happens, right? Those 2 little blips there, you may be wondering what those are. I call those the Tway effect, because that's when we sent our friend Tway, the project manager that worked with us, back to the clinic to remind the doctors, like, you remember that you loved these videos? You remember how much that like you wanted to do these? And we got a transient blip, but it didn't coalesce into some sort of lasting effect. Oops, sorry about that. And I think partly that is that this question that we got from doctors, right? Which was, there was all these criticisms of like, why do I have to do this? And they said, well, why do I have to log into another website? This isn't very convenient for me. So as you heard, I was a software engineer at some point in my life. I thought, well, maybe software can fix this. Maybe we can use middleware technology like this company Zelf, which is basically a tool that connects an Epic client to an outside, it creates a bridge essentially between our Epic and something else. So we were able to embed in Epic advanced care planning videos such that someone could hit an order and it would send a video to them so that their patient could see that. And then the doctor said to us, no, that didn't work that well either. I want it sent to everybody. Can't we just automate this? So sure, we tried that too. We actually created a rule in Epic that detects anybody that's coming in for an annual wellness visit, well, 65 and up, right? That didn't have an advanced directive and that was coming in within the next 7 days. And we sent them an email on behalf of their doctor, branded, saying, we're looking forward to your appointment coming up with Dr. Gonzales. At our health system, we really believe in the importance of advanced care planning and making personalized care a priority. Here's a video if you need some information about why this is important, and we're going to talk about this at an upcoming visit. Pre-pandemic, we did this for a year, and we got 4,300 advanced directives returned. Which was remarkable and exciting and wonderful. And it required 0 clicks for us. So we spent, though, 42,000 emails over the course of a year, automated, but totally automated. We had a 65% open rate and a 10% advanced directive return rate, which was remarkable. But what I'm going to share that isn't on this piece is what we got were mostly old advanced directives, which was useful, yes. But there wasn't a lasting effect because what we were reminding people to do was bring in an advanced directive that they already had. It wasn't incentivizing new advanced directives. It was incentivizing, oh, they don't have that, I should bring that into the clinic. The biggest thing that we did, which we thought would be most helpful, and I promise to get to a more hopeful piece in a second, but I just want to set the stage for where we were, was that we actually had a system-wide effort around a metric across all of our individual clinics and said, like, all right, we're at 20-something%. We want you to increase by some percentage. And that set a gate for the C-suite executive compensation. It didn't mean that they had to fill out a document. You had to document one way or another that there was a conversation, that they were on the path, something around that. We weren't trying to force it necessarily, but to incentivize the conversations. And with all of that work, I'm going to show you our inpatient and outpatient over the last number of years. So we had the total effect of maybe a few percentage points, right? If you squint, you can kind of see that there's like a little bit of change there. And we kind of finally said to ourselves, like, we're continuing to not necessarily iterate. Like, we're trying more strategies, but not really listening to the feedback that we're getting. And I think that that's, something that we're all learning. It's not just us that are struggling with this. The academic response to advanced directives, like, is all over the map. And some of them, like maybe this one on the screen, I vehemently disagree with. But I appreciate the need for discussion around this within our field and recognizing that it's not just us that are having this problem. But that our group has really taken this sense that, like, when there are barriers, when there are like breaks in the road, we really need to take a step back and think about, like, what are the true reasons that this is a challenge for us. So we did a number of focus groups across our health system, and we found in particular 4 things that we really wanted to work on and target. One was the notarization problem. Huge challenge in terms of getting these documents returned. 2, not surprising, the electronic health record on both sides, both for the docs, the APPs, as well as patients and families. 3, we really loved and had used a long form for a long time because we believed in the research of Rebecca Sidori and Prepare for Your Care. And it's a great form. What we heard, at least from our patient populations, is that it's wonderful that it's big font, but it's 18 pages and I get overwhelmed looking at it. And I don't know what to do. I put it away because I'm like, there's just too much here. And the 4th was, particularly from younger folks, that the living will part was hard. I don't know how to prepare for that. And so what we did is we took some inspiration from all of these things and thought, like, what is super difficult that exists in our world that is still kind of painful, but we all still end up doing every year. And the idea came around of taxes, which is not everybody's favorite topic, but we all somehow end up getting it done. And it turns out a lot of people in this country end up getting this done through TurboTax. And took a lot of inspiration, particularly on the electronic health record on the Epic side, of trying to say, like, what if we could create a very simple interface that allows clinicians to put in a few easy to use choices about who someone's person is, and to be able to use a very simplified format that's easy to engage with. And then Epic just kind of creates the form and pieces for you. And so that's actually one of the huge things that we built out. We took this TurboTax design and said, like, all right, like, what does TurboTax do well? And there's actually huge case studies on this in various areas. We similarly have created a pulsed tool around a similar thing, where it takes and says, all right, we need to give the user some feedback. So there's clear color coding, there's check marks, there's clear signals when sections are complete. And when possible, we wanted to be able to make it easy for people to fill this out. So we auto-populate any existing information that can be there. I'll show you a little bit of the design in a second, but we recognize that, like, okay, fine, we could improve the EHR, but that was just like one strategy that wasn't quite enough. So really what we did is work to create a new designation within our health system. And this is a not legally recognized term in any of our 7 states by purpose. We could call it the trusted decision maker because it resonated, because it made sense. We understood what that meant. But it didn't get into any of the state-used language around, for instance, an agent or a surrogate, and we have 7 states, right? So the languaging of all of this was very nuanced and trying to pick a middle ground. But we wanted to basically select and create a policy within our health system that said very clearly, if a patient of sound mind, right, if they have capacity to make these decisions, comes in and expresses their desires for who they want to make decisions for them in case they were to become incapacitated to one of our medical providers, and we restricted it to a physician, a nurse practitioner, or a physician assistant. And that person documents in a particular way using this particular tool in the EHR, that Providence will accept that as good faith effort and will respect that decision in the absence of some other notarized advance directive that gets turned into us that we didn't know about. And that felt really important because I think for me, like, I was just attending last week at one of our hospitals, and it strikes me and is so interesting to me that I'm allowed to make so many decisions about with people, right, around what kinds of care, and be in family meetings with them and help talk through things and bring people off of life support. And yet, at least in most of our states, I haven't been allowed to concretely put in a decision maker. And so that policy, as you might imagine, it took Ira and I 2 years of meeting with legal to be able to craft a policy that was worthwhile. What we kind of came up with was this sort of 3-part form where people could put in their trusted decision maker, an alternate trusted decision maker, some sort of basic designation. They could, if they want to, give some guidance to the healthcare team. I'll dig into that in a second on the next slide. And then the person seeing them would need to put in some determination of capacity, some piece that our lawyers felt like, oh yes, we're sure that this is addressed and we can move forward and use it going forward. As far as the guidance, we kept it very simple. And in fact, our tool in Epic really pre-populates this first one, which says, I'm not really sure at this time which of the statements below I most agree with. I trust my healthcare decision maker or trusted decision maker, healthcare agent, to do what's best for me. So we included some language around the 3 other sort of standard options, right? So full treatment on one end, a more like comfort-focused treatment on the other, and on a selective middle ground. But we found, and what we felt like, is that providing this easy key way to be able to appoint somebody and then building it into Epic, as you'll see, really made it very simple to combine all of these things. So this takes 5 clicks, 2 minutes and 27 seconds. We rounded up on the slide, which is a bit of time, but actually a lot of it can be done in the pre-visit workflow. It takes into account all of the emergency contacts from the patient's Epic record and gives you a choice of like who from that list could we put down to be a trusted decision maker. It auto-populates that first wish of, I don't really know who it would be, and the doc can or provider can certainly go in and change it, but trying to streamline and make it easy. Then there's an attestation of capacity. As you can see, though, all of this workflow is like very simple and easy in the middle of the screen, right? Like big colors, tried to make the fonts super accessible. And at the same time that you're filling that out, on the right side, the document that's actually being generated is previewed, much like it would be in TurboTax, right? Where you're like interacting with some GUI, I'm going to say for short, a graphic user interface. And then you get some feedback on what this looks like so that you know that the document actually comes out is valid. When you click sign and submit on this, 2 things happen. It drops a note into our Epic chart, which says this is the person's trusted decision maker, and here's a reference to the policy in case people aren't familiar with it. And so you can use this to make decisions going forward. But then on the 2 closest, or on the printer closest to that workstation, we print out a pre-populated simple advance directive, so that in case people want to be able to take that and make it legally valid in other places, they can have everything on there in one step to be able to get it signed, either witnessed or notarized. What I'm going to say is I feel like all of these pieces together in the same clinics that we're working in that we were before have led to a tremendous change. In our 3 pilot clinics, we are now at 85% advanced care planning rates, which just honestly feels unbelievable to say, given the story that I started out with. But I don't want you to necessarily take it from me. I'd love you to take a little bit too from the experts that we worked with to be able to craft this. So here's a comment from our senior counsel which says partnering with your Department of Legal Affairs early in the process is key. Department of Legal Affairs, which is what we call them at Providence, considered all relevant laws across the Providence footprint and guided the Institute for Human Caring in creating a system-wide policy, tool, and resources which appropriately and comprehensively consider these legal requirements. For those of you that work with lawyers a lot, you'll know that this is a ringing endorsement of the policy. The fact that Stephanie would allow her name to even be put up here and to be saying that like the DLA, the Department of Legal Affairs for all of Providence will support these things. They have a different language. The other person I'd love you to hear from is Derek Williams. So I'm going to play a video from Derek, who runs the same clinic that we tried that pilot in years ago, where we had the TWA come in and try to show these videos. Here's Derek's perspective on doing this.
Years ago, before the TDM tool, I couldn't get my numbers above maybe 30%. I talked about it with every patient. We filled out forms. I sent the forms home with the patient, but the patients invariably wouldn't bring them back. It was just too long and difficult for them to complete. But with the TDM tool, I'm able to quickly, within just a few minutes, raise the topic, talk to the patient, address their issues. And my rates that I couldn't get above 30% for years, despite my consistency, the TDM tool allowed me to get about 80% or more of my patients to identify their trusted decision maker, have the conversation. It helps me talk about a difficult issue with my patient. I think it helps them talk about it. It makes the patient feel cared for, that I'm not afraid to bring up maybe complex issues, talk about the truth of their condition, and also the importance of having somebody to advocate for them if they ever encounter a time when they couldn't speak for themselves. And I think it does make the patient feel respected. It makes them feel that they put your trust in you as the clinician. It validates their choice to stick with you as the clinician. So I think that's probably one of the best things about it, is it opens an area that a lot of people shy away from, but patients really want to talk about. And once you go there, I think it really does deepen that relationship with your patient. Patients sometimes are hesitant. They're anxious. Sometimes they worry about their health, but you can be sure that patients want to talk about this. 80% of patients want to talk about it, and they also know who their trusted decision maker is. And once you've done this and you walk the patient through this process, that anxiety invariably decreases, and they really appreciate you addressing it. I saw a patient for a routine Medicare wellness exam. Patient was stable but had multiple chronic problems. We talked about those. We identified the trusted decision maker. A family member was there. And unfortunately, within a few weeks, the patient had an unexpected health decline and passed away. When I talked to the patient's family over the phone, one of the things the family said is they were really grateful to have gone through that process with the patient, because they didn't feel the worry or anxiety or guilt about what was the best decision to make, or what would their loved one want in those circumstances. So it just shows how important these things are. For me, I use the Medicare annual wellness visit as a reminder to address this advanced care planning. Every single time I see the patient for their Medicare wellness, I either review what's on file or I get the patient's trusted decision maker and use the TDM tool. The old process was clunky. The forms were too long. It took too much time. But the new process, it's integrated, it's streamlined, and it's much easier to guide patients through this process and identify their trusted decision maker. And they leave with forms that they can take home and have the conversation with their family. I can certainly see a tool like this used at facilities or health systems outside of Providence. It's compact, it's efficient, and it really addresses the need of the patient. So my vision would be to see it expand inside of Providence, and also I definitely see a utility for it outside of Providence as well. Clearly, healthcare is a team sport. We can't do all those things by ourselves. We need to offload things that are appropriate to offload, but things like end-of-life care, that's just something that's core to who we are as physicians. And I think our patients really expect it from us to bring this topic up, to talk about it and walk them through it and answer any questions they might have.
So I want to acknowledge that sounds a little bit like a marketing video, and it is. It's an internal marketing video actually that we're using. It's not like we're selling this or anything. We're happy to share whatever resources we've created around this. But we're expanding because it feels like it's working. And Derek, I would also say, is just a champion of good work, which I love. Like, he is not, sometimes we've had to rely on primary care folks that are really good at palliative care. Derek is a wonderful family medicine doc. Palliative care is not necessarily the specialty that he has chosen, and yet we've made it really easy for him, and he's also then made it easy for us. So this was he and I back a number of, like, about a year and a half ago now. We were still masking. And listening to patients that had these done to try to understand and get a better perspective from patients around what their perspective was. And theirs was overwhelmingly positive around the old forms were too hard and this was much easier, wanting to be able to talk through these things and be able to recognize that, like, if we can, this was my biggest takeaway, is that because there's so much trust in these environments, that it can be a very safe space to have these conversations, that we just need to engage and have these conversations. Based on that, though, we have changed our marketing a little bit. We've moved away from, like, do you have an advanced directive, to this campaign of who is your person, which has felt like it resonates at a deeper level with the patients, the families that we have worked with. We've done this not only in a number of groups across Los Angeles, but we also recently partnered with the LGBTQ Center here in Long Beach to understand how well this works in the LGBTQ community. Fascinatingly, one of the things we heard most as a motivating piece around starting the TDM discussion there is not only who is your person, but who is not your person. And I think that's a lot because of histories of trauma, of families of origin, and recognizing that sometimes it's easier to identify the people that you don't want to make decisions for you as an entryway into having this conversation, which I thought was a fascinating and sad, but also fascinating way of approaching the conversation. So right now, these are stats from March. I should have updated them. We're at 2,900 TDMs in the 3 clinics that we've been doing since. And yes, it is a bit of a flat line, but you can see that, like, we're talking about in not the single digit range. This is like 200 to 300, sometimes as high as 350 over the course of individual quarters in terms of having these. And we're continuing to make progress. I want to say, though, it's not all roses, and that's partly why we were giving this talk at the coalition, because we recognize that there are a few key limitations. One is it's only accessible within Providence right now, and that we're willing to share, and we are sharing with others within California in particular. But one of the challenges is that although we will respect this, if one of our patients lives close to another hospital that's not a Providence hospital, it's not clear that another hospital would respect this designation. And that is a true limitation that I think we need to work on. The second is totally by design, right? That care preferences are generalized, but in some scenarios, I think we need probably more robust conversation planning. I tend to not worry about that so much because I think the initial document is the beginning of a journey in having these conversations, and then the more iterative, deeper goals of care conversations, people get sick, are important. And then lastly, which I think makes this definitely harder in terms of who can do the final documentation, is that our lawyers were very clear that this needs to be signed by a provider, somebody with malpractice insurance read, right? And so that is a limitation that we are trying to work through and think through, but it did make them feel more comfortable. What I would say is I have very mixed feelings about that, because I learned most of the great palliative care conversation skills around talking about this from a social worker who'd been a social worker for 40 years and a chaplain who'd been a marriage and family therapist for 45. And so I think that on some level, this discounts those skill sets, but we're looking to broaden this certainly with time, recognizing, and it'll take us some time to prove that there are no bad outcomes and continue to iterate. One of the exciting things, and then I'll close here, which is that we gave this talk at the Coalition for Compassionate Care in California, and there was a lot of excitement in the state to be able to work together. And that's really what we were trying to do, is create a coalition with Jennifer Ballantyne, who runs that. And we're now in conversations with a few funders trying to see if we can cobble together a government affairs work group for California to be able to change the laws, to be able to think about inserting into the California laws around surrogacy that if someone has the capacity to make the decision and has appointed somebody in a verbal designation, that should be respected. And it turns out in conversations with a lot of other health systems in California, a lot of people have unofficial policies around doing this that have yet to become official. And so I think one of the biggest learnings I've had is that we've all created some workarounds or ways to do this. And so our goal is to be able to share and to be able to change policy long term, hopefully to be able to make it easier for patients and families to do this. So I'm going to stop sharing slides there, but happy to take any questions that came up.
Wow, thank you very much, Matt. And we encourage people to type their Chantel's doing the right thing, clapping going on over here. Very inspiring. Now people see why we wanted Matt to present and talk about some of the things. I will say, having worked with advanced care planning for so many years, I love the beginning part of, oh, we tried this, we paid people, we gave them an iPad, like all those things that we've also tried. Even the free beer doesn't necessarily make it work. So this is a really interesting concept. So I hope we can have a bit of a discussion. So there's two questions already. One is, how is this process addressed with patients with dementia? As you mentioned, people have capacity.
I wish I had a better answer for it. I don't at the moment. And I think a lot of this is going to be trying to move this upstream. It's partly why we're working with IH&I around the age-friendly health system work. Because I think that slide that I showed earlier, right, around like these three crucial conversations, and I kind of alluded to this, I think we're still catching people too late in these conversations. And there's like a huge gap between 18 and when you develop a serious illness, hopefully, not always, but hopefully. And so I think we need to really think about what a good day looks like at 65, what a good day looks like at 55, and to be able to like create routine ways to have those conversations earlier so that we're not in the situation that all of us are faced with day in and day out now of like, I don't know who the right decision maker is. There's family strife and the person can't make those decisions. So my true answer to that is like, we need to continue to move towards creating systems that help and help hold people during those moments longer term.
And as you say, starting early. So if I understood you right, someone with dementia couldn't be doing
this.
That's
right. Yeah. Because they need to have the capacity to understand the discussion. So we would not include them in that. But I a few years from now, I'd love to have higher enough rates of advanced care planning earlier on that we're not having to face these conversations as much last minute.
Sure.
Can the provider signature?
Can the provider signature be electronic since this form is also electronic?
Yeah,
how does that work?
So yes, we do that. And we're working actually now on trying to figure out a way if the individual signatures on it could even be done through like a QR code where you like use your iPad and something like that and scan it in. The technology around that is good right now, but we're trying to figure out how to make that work at scale and securely in this ultra need for cybersecurity world. On the provider side, it's interesting. In one of our states, actually, doctors are allowed, any healthcare person is allowed to be a witness for these forms, which actually in Washington, in our communities in Washington, that's really, really helpful. None of the other 6 of our states have the ability to do that, but we haven't introduced because it's only one of 7, and that doesn't meet the threshold for me to change the Epic build. So there is a way. The short answer is yes, there is a way to do it. But we haven't invested as many resources around that piece because we're trying to prove that it worked first.
Interesting. So if I understood you right, this is all part of the EMR. So it's put in, and I love how things can populate. And then can you talk a little bit about how, so you are still trying to encourage people to do an advance directive. Did you try with people who weren't the security guards?
Yes. Yeah.
Because that's something that Hope and I became notaries because we find this happens all the time. And one of our health systems says, oh, it's fine. Lots of people can become notaries. The other one says, no, you can't. So I'm just wondering, that was 2 questions or many questions, but what is the process then for completing the advance directive, and how's that going? And then about that notary piece.
Great questions. So we're now in process of building some dashboards and analytics that look at like how often we get a return document based off of this, right? Because the workflow creates something in Epic that's a note that's tangible that we can use for decision making going forward. But on the printer closest to you, right, which in many of these rooms is like on the way out the door of the clinic, someone can pick up the stack and say, here's everything written down, right? So we have had success around training the front desk staff, but that actually was harder than the security guards, because the front desk staff are like trying to move through and check people in and make phone calls. And they were so busy that it wasn't the easiest solution. What I would say is, an employee caregiver side, they loved it because Providence paid for them for their certification for them, on the guarantee that they would notarize documents for our patients, not just documents, but only these documents. We made it like very specific and clear. Like it can't be mortgages or whatever that need to happen. And what I would say is they loved it too, is because they were able to use this for extra income in their personal life. So we said, while you're on Providence property, like you can only do these, but you're allowed to do whatever once you have that license within your own personal life. I would say it worked moderately well. It was in most of our states, it's about $500 per person to train. And I recently have greenlit another pilot for it in one of the clinics that focuses in particular on this, but it's I don't know, in most clinics I've stopped funding that because it's been a challenge, because the rates of advanced care planning are still so low. In these few ones where we've like adopted and worked on the TDM, like that feels like a very clear path forward, next step.
Okay, how receptive were patients to the trusted decision maker as the MD or nurse practitioner? Is there any other criteria for this process?
I would say, people can choose whoever they want. And I think that as long as the conversation is held from a trusted environment. So like, we've been talking with our PCPs, like maybe this is, unless you're really worried about someone, maybe this isn't the first visit that you see someone. Maybe it's the second or third, and build that trusting relationship, because we heard that was really important. Universally, the patients that we have talked to in focus groups, which is not a perfect research methodology because they got to sign up and show up for that, right? So you're self-selecting, but those people do tell us that it's been a positive experience for them. We haven't heard a lot of backlash around putting it at this particular level.
Great. Daniel asks, thanks, Matt. Very nice work. You mentioned sharing the TDM tool outside of Providence in California. Are there other plans for dissemination? For example, if my system's legal department approves, might we work to make it part of our Epic build? That's what I was thinking when you mentioned Epic build, concrete suggestions there.
Absolutely. We're happy to share all of that. In fact, what's one of the things that we're thinking about trying to do is creating a toolkit and put it like kind of packaging things together for people around. So I love Epic. I know Epic is a 4-letter word to some people, but I truly think that like with the right design, you can make it better. partly that's right, that I've spent a month at Epic learning how to build code for it. And I have someone on my team now that does that. I don't get to do that as much. I wish I did. But we can certainly help with those things. We're actually in a process of including and updating that. The other thing that we would be happy to share for sure long term is our Pulsed build, which is kind of very similar to this, which is like a TurboTax for Pulsed forms. We called it Turbo Pulsed initially. Yeah. We're in process of, and this gets very technical quickly, so I'm just going to say there's a programming language called Smart on Fire that kind of you can create an app, kind of like an app store for iOS, and download it into an EHR nowadays. And so we're very close to releasing a Smart on Fire app for Pulsed forms that will just be freely available so that people can import it into make some customized changes for whatever their states are, and be able to use sort of a plug and play app in Epic, because the Epic build can get complicated quickly.
The Turbo Pulsed, is that just for Epic users?
So we will have only tested it with Epic because we only have Epic, but Smart on Fire, what's great about Smart on Fire is that most of the modern big EHRs can read this Smart on Fire type of technology. So for instance, Cerner has a way to plug in for this. And it's like a small grant that we've been working on for about a year to be able to put this out and release it.
And is that an e-Pulsed kind of a thing, or?
Yeah.
Okay, well, we will talk further about this. So in Hawaii, Queens, Hawaii Pacific Health, and Kaiser, so those are our big systems. They all use Epic, and then Adventist Health, they use Cerner. So with those two, we have lots covered. So we'll follow up with you about this because we're really interested in making that happen. Okay, interesting. We won't go down the Pulsed rabbit hole, but thank you, because that seems really interesting. So what I just shared, the three main systems here are using Epic. And are you working with Kaiser in California already? Are they part of that group?
Yeah, so Kaiser in California, interestingly, I don't think I'm outing them, but they have an unofficial policy that's very similar to ours, it turns out. Around this trusted decision maker. I don't know that they want that like fully set everywhere. So like maybe amongst this like small crew of folks, but that was one of the more interesting things around doing this talk is Susan Huang, who's their palliative care lead here, said like, okay, let's work together on like thinking about changing state law here in California. And so they'll be part of the collaboration that we have here, particularly in California. And I don't mean to focus just on California because we have certainly 6 other states to think about. We, a year ago, had a bill floated in the Washington state legislature that got some traction, and it'll get refloated next year. But as you all know, it takes time to build the legislative agenda and many years of work around that and advocacy. So my hope is that over the next number of years, it'll become easier and easier amongst all of these states. Because the bottom line, I feel like, is that we've made some of these things a little too hard. And the reality is, like, for patients and families, making these decisions is hard enough. So if we can simplify things, no matter what that looks like, I think we can get back to truly having the hard work be the focus, which is what I think we all want to do, which is have these conversations, make people feel as good as they can, and honor their wishes. So,
right. Very interesting. So for folks who are on the call from Hawaii, if you're interested in exploring this further from Kaiser, from Queens, from Hawaii Pacific Health, let me know. And we can talk further. And Matt seems to be happy to share. So that's good. But maybe we can, have a Hawaii approach about how to do this, or at least do some, pilot and try it out. So I guess, thinking about this, Matt, if there was an interest, what would your advice be? Finding pilots to start? We could, as we say, cockroach, meaning to steal. We could steal what you've done.
Oh yeah, we are happy to share everything. Everything about happy to share the policy. Happy to, I think even our lawyers would be happy to. That's honestly where I would start, to be totally honest. And I know that's like a hard start
Mm,
barrier, but I think you're welcome to reference us as like there's a large health system on the West Coast, and like
mm.
we have 52 hospitals, 1,100 clinics, 35,000
Yeah,
nurses.
a
Like
little bit more than us. So,
we're big in terms of size, and so like we haven't yet seen things go wrong in our pilot sites, and we're endorsed across the entire system level. In fact, I just signed the update of the system level policy without any changes,
oh, great.
and legal was fine with it. So I would start there, because unless you're going to be able to necessarily get legal backing from like your lawyers, it's a hard
Sure.
conversation to have. But
Yeah.
happy to have us referenced as a place where this has been successful, um, and also in any of these other areas, whether it be Pulsed or some of the AI work long term that we're hoping to share and talk about more broadly, like we're a part of a health system, but our goal has always been to share openly with people, because it's gonna take all of us doing really good work to be able to change the future.
I was going to say to people, Sarah Roxa, who's a geriatrician, she put in she's interested. So far Queens has weighed in of their interest, but other people you can let me know or put it in the chat to see about moving forward. A question, how frequently is the form reviewed by hospital staff when there's multiple admits?
That's such a good question that I don't fully know the answer to. Epic does record everything, right? Everything that you do. So we are in the process of building out reports to see how often things are tracked. One of the things we just built an age-friendly dashboard around the 4Ms from IHI, and as part of that, we're looking to track how often people click into it, and how long they spend with it. It's taking a little more time to be able to understand that. But I think it's a fascinating question, because we spend all this time building these tools, right? And do people actually use them? Is it the
Right.
right way to think about it? I don't know yet.
Yeah. Okay. Well, and that's good to know because we also, of course, like IHI and their materials as well. So that's good. Okay. Kaiser, thank you, Dylan. And we can reach out to Hawaii Pacific Health too to see that. Keep putting questions in the chat. Before we talked, I wanted Matt to just talk a little bit. He mentioned interface of AI and palliative care. So if you wouldn't mind just a little bit about what you're doing. And
Yeah.
I said, oh, good, I can see us inviting you for a second talk. So can you talk a little bit about that?
Yeah, happy to. AI, I think, is scary to many people. I have found a lot of excitement around it because one one fact I'll just say is that like the human brain, right, has about 100 billion neurons. The most recent GPT model has the equivalent of 175 trillion neurons, which is like just mind blowing. So it's good at a lot of things, but it's also bad at a lot of things. And knowing where the right places to use it are really important. We're using it in two ways right now. One is we've embedded GPT-4 into Epic, and it reads all of the notes that are submitted by a clinician in the background. And this is not like a public GPT, right? We're not sending it to OpenAI. It's like on our site. And it identifies whether there's a goals of care conversation in the note or not. So I don't have to teach people anymore, like type.acp or go to this particular place in Epic or do this workflow. It just finds the conversations, and we have a 92% sensitivity rate and a 93% specificity rate on it, and identifying those conversations. And then it tags them and puts them along with all the other conversations around what's meaningful, so that you're not having to dig through 500-600 notes looking for all the most recent goals of care conversations. And then more recently, I got bored about a year ago and started playing GPT on my own, and I built we're calling it Empathy AI. It's AI conversation simulator based on merging of like good conversation communication techniques. And what it offers is the ability to simulate having serious conversations, difficult conversations with AI patients. So that you can practice those conversations in the safety of your own home, where you can understand what is going well. There's a coach that for a while I was calling it the Oracle, but now we're calling it a coach or a get help button, that can give you real-time tips on what you might say next to the AI patients. And what I would say is it feels really real. Had a lot of these conversations over the course of my lifetime, and the AI patients are not as good yet as real patients in terms of like their believability, but they're almost there, and we're starting to use it for trainings because we, over the last 5 years, has trained 5,000 people in communication techniques in hour-long workshops, and that works, but it takes a lot of time, and it's really hard to do, and this takes not as many resources, and I think is just as good, if not better. And that's really fun because now we're able to like actually truly scale communication training across like PCPs and the like. They can do it from their desktop. They talk back and forth to an AI avatar, and it talks back at them. So I'm loving it.
So if I understand right, so maybe you just said it at the end, there's an AI avatar who's simulating being the patient.
Yeah.
And then as the provider, you can practice and you get feedback somehow, like that was crappy, or start crying or whatever.
Yeah, you can. So it generates a score report at the end and gives you like how you're doing in terms of recording like major skills within communication domains. But also it has real-time help. So if you get lost, if I get lost and I don't know what to say, I can hit a button and it'll give me a really good suggestion of what to say next.
Wow.
And so there's learning that can happen there, and reinforcement that can happen. It'll say things like, well, you're doing really well at this. Here's a concrete suggestion, 2 sentences that you can say next to this patient.
Is it built off a certain type of training, like Vital Talk or?
It's not necessarily, but I would say that like all of the techniques that we all use around this, right? Like because it has access to all of these things, it knows what a wish wonder statement is. It knows what what the nurse acronym is. It knows when you're naming an emotion, right? And it can like, detect and identify those things and give you actual verbatim feedback, kind of like all the good communication courses do. Like you said this, the patient said this, that worked. You might want to try something else instead. And so I think, I mean, I'm very excited about this. Long term, I could imagine that it, some people might hate me for saying this, could even become like a board certification exam around this. Like the multiple choice test that I take for hospice and palliative medicine is not representative of my skills as being able to have these conversations. Like the A through D choices, like that's not meaningful. We need to have better ways to be able to certify people using something that's truly thoughtful. And I think these tools long-term could do that.
So if people wanted to get a demo of these tools, is it something available for outside of Providence folks?
Yeah, it's not quite public yet, but if you all want me to come back, I'm happy to like pull together some demos and can show you what it looks like kind of real time. You can do it. I've just submitted it to the Montreal conference. They're having an innovation award.
Good.
And I'm hoping that maybe it gets selected in the next week to be able to pitch it. But we're going to be working both within Providence and then external to Providence. And the communication simulator, empathy AI, right? Like that's going to take us another 6 to 8 months of testing to really, and then we'll probably like release it and other people can use it. I think the GPT one will be very easy long-term to replicate, because what we're really doing is we're creating a really reliable prompt. And almost every health system, I think, in the country is eventually going to like integrate some sort of AI into their medical record. And so we're trying to integrate these things early. And from a palliative care perspective, I worry if all the tech people do this for us rather than people that actually know what these conversations look like, because they're going to get it wrong.
Well, having been raised in Silicon Valley with a lot of engineers, I can say that I appreciate this, that there's a certain, you need skill sets. And that combination that you bring, of the tech plus the palliative care training. I'm super interested. We can talk offline about inviting you back. If a couple of people have written that they're interested, feel free, if you're interested, put it in the chat. I like both the chat GPT and thinking about how to scale the training, because we've been doing really good stuff here with Vital Talk, but there's a smaller number of people and they have to attend training and all that. Like, wow, how could we use AI in a good way? So that's really interesting. Thank you.
Yeah, I'm happy to share more about it. And there's research around some of this too. It's fascinating. Around like the comparison of physician versus GPT responses as they're perceived by people, and there's a real difference. Like GPT actually creates more empathetic statements,
which is very sad.
Very sad.
It's really interesting because we're not talking always about palliative care docs, but just normal docs who, I thought, for instance, your colleague who spoke about how he incorporates this into the wellness visit, how many times have I heard doctors say, oh yeah, it's on the checklist. I ask if they have an advance directive.
Yeah.
And that's their empathetic conversation. So it could also be quite helpful for other doctors who might not have had the training. So yeah, super interesting. Thank you very much. That's great.
I could talk about all this stuff all day. So
so could we. I missed a question. Linda did ask another good question. Is this billable by providers when completed? And I'm
like the
TDM?
TDM? Yeah, it definitely. If they go over the 16-minute limit,
it qualifies under the advanced care planning thing. Okay.
99497.
Yeah. I was going to say I should know that number, but I didn't. It's good. Excellent. All right. Well, thank you so much, Matt. This was great. You gave us lots of things to talk about. So appreciate you spending your time and expertise with us. And as I mentioned, if people are interested in looking at what this might look like in Hawaii, please drop me a note and contact me. But thank you again, Matt, for coming.
Thanks for having me. Honestly, super, as I started, it was just really lovely to meet you and hope. I've been reading your words for over a decade, so just so fun. Thank you.
Good. And now
you all do.
You get to see some of the other part of our extended team. So thank you.